Welcome to Brain Info Live, for everyone in the brain health community. Brain Info Live is about hope, health, support, education, and you. Whether you're living with Alzheimer's or a caregiver, family member, or loved one of someone who is, Brain Info Live is here for everybody.
Hello. Hi, guys. This is Dr. Young Trin, Chief Medical Officer of Irvine Clinical Research, but transitioning that title over to the Healthy Brain Clinic here in Long Beach that we just launched with that. And that's where I'm sitting now. Welcome back. This is our 18th episode. Number 18 of Brain Info Live in Southern California, and our first episode in 2023. So today we're going to talk about hearing loss, guys. We're going to go over how hearing loss is somehow connected to dementia and other cognitive issues, as well as how often we should be getting our hearing checked and how hearing aids may make a difference. We brought in a special guest today who is a master on this topic, and I'm excited to be chatting with him. But what we'll do first, guys, is we'll get a jump start with John Lewis, known as J. Lou, the fitness guru from Atlanta, Georgia. John Lewis.
Hey, I'm J. Lou, your fitness guru. I want to welcome you to Brain Info Live. Today, if you have a box, a chair, a stool, a bench, if you're outside, today is the workout where we're gonna work on that core, those legs, and also we're gonna do a little bit of isometric with the upper body. So let's get ready in 5 seconds. All right, watch my form at all times. We're gonna start from the calves and work our way up. All the way out, calf, raise. 5, good. Toes out. 4, and we have 5, good. Toes in. 5. Good. Take them up. Leg forward. 5. Switch. 1, 2, 3, 4, and 5. 1, So let's get ready. Squat. toes out. Squat. 1, 2, 3, 4, 5. Great job. Now we're gonna really engage that core, abs, and extend out. Squeeze those glutes. Ready? Take it off. What? Here. 5. Great workout. This your boy J. Lou, your fitness guru, and see you later. Bye.
All right. Thank you, guys. Boy, I broke a sweat looking at J. Lou, and my office staff actually worked out as well here with us. And we got some good videos for you guys right now to view and take a look at. That's lined up. So let's go ahead and show that.
Set, hut. 1 steamboat, 2 steamboat, 3 steamboat, 4 steamboat.
Okay, last play. We got this. You ready?
Great. Blue 42, AB, AB.
Drink bean, and big boy, and what? What?
Can I get the again?
Sorry, what? Sorry, what's that?
Working in a loud environment can damage your hearing. Whether you're exposed to loud sounds for a short period of time or moderate sounds for a longer period of time. For example, a busy intersection is approximately 85 decibels. Exposure to this level of noise for 8 hours or more can cause hearing damage. Forklifts are approximately 91 decibels. The exposure limit for this level of noise is 2 hours. For a nightclub like this one, when noise levels reach 105 decibels, damage can occur in 5 minutes. If you move closer to the speakers and it goes up to 110 decibels, damage occurs in just over a minute. It's not just how loud the noise is, but how long you're exposed to it.
Sorry, what's that?
Wearing hearing protection blocks some of the sound from getting to your ears and can prevent hearing loss.
What's the occasion? Nice, I have those too.
In fact, wearing hearing protection can actually make hearing voices easier while in a loud environment.
Hey, what can I get you?
Can I get a gin and tonic?
Yeah, for sure.
A rum and coke.
Sorry, what?
Rum and coke.
I can't hear, man. Thanks.
So, start now and protect your hearing.
String bean, string bean. Corner fade. And hut.
1 steamboat, 2 steamboat, 3 steamboat.
Yes!
Noise-induced hearing loss is permanent, but preventable. Always wear hearing protection while working in a loud environment.
All right. Great video and a great lead into our discussion. I'd like to introduce everyone to Dr. Douglas Beck. And Dr. Beck began his career in Los Angeles at the House Ear Institute in cochlear implant research and intraoperative cranial nerve monitoring. By 1988, he was the director of audiology at St. Louis University. In 1999, he became president and editor in chief of audiologyonline.com, speechpathology.com, and healthyhearing.com. Dr. Beck joined Audicon in 2005. From 2008 through 2015, he served as the web content editor for the American Academy of Audiology. He worked as a senior editor for clinical research at the Hearing Review and also adjunct clinical professor of communication disorders and sciences at SUNY AB. In 2019, he was appointed vice president of academic sciences at Audicon Inc. Dr. Beck is among the most prolific authors in audiology with more than 211 publications. Although he officially retired from Audicon in March of last year, 2022, he became vice president of clinical sciences for Cognivue Inc. in Victor, New York, starting in April 2022. Dr. Beck continues to consult for a number of professional and private concerns. So, Dr. Beck, welcome to the show. Impressive,
Thank you.
impressive bio.
Well, and now we've used up all the time going through the bio. So thanks very much. Have a nice
Yeah.
day.
Right. Wow. So tell me a little bit about yourself and about what audiology is and how it relates to cognition and all that.
Yeah, so audiology is an amazing science. Audiology has everything to do with from your outer ear to your inner ear to your brain. But when we talk about it in terms with Dr. Trin, we're talking about the overlap between cognition and hearing and audition. And if you go back to 1949, there was a fellow named Dr. Michael Buston. He published in the Journal of Speech Hearing Research. He was saying, there's a lot of overlap between auditory processing and psychology and language. And it's just really a matter of which lens you look at it through. So audiologists are looking at how speech sounds have to be interpreted by the brain. So this brings up just a very, very basic but important foundational piece of knowledge, which is that hearing is just perceiving sound. Hearing is just detecting sound. That's it. Listening is when we apply meaning to sound. Listening is when we comprehend sound. Listening is when we untangle that neural code going from our ear to our brain.
Wow, that's pretty significant. It's kind of what my wife tells me. Are you listening? Are you hearing? I hear everything.
Right.
Absolutely.
Right.
So the big question, yeah.
No, that's
So
a great observation because
right.
the hearing and listening are not synonyms, and this becomes a big deal because when people say, "Well, I don't think he's listening," "Well, I don't think he's hearing," those are very, very different things. Hearing is just perceiving sound, and as you just said, right? If I'm not paying attention, if you're not paying attention, we're
Right.
certainly hearing sound, but we're not giving it any attention, so we don't understand what was said. It's sort of like if you and I go to Paris. Now, I don't speak French. Do you speak French, Dr. Trin?
Only a few bad words, maybe.
Okay, so if we're sitting in a cafe in Paris and there's people all around us, we can hear them all. But if they're speaking French, we probably can't, pay attention to them. We can't comprehend what they're saying. So there's a big, big issue here. When you're talking about listening, that's the ability to attribute meaning to sound. And this becomes very important when you think about cognitive issues, because one of the major complaints of all time that audiologists deal with every single day, as do hearing aid dispensers, as do otolaryngologists, the main complaint that we hear is I can't understand what somebody is saying. I can hear them, but I don't know what they're saying, and it's worse in noise. So that becomes the ability to understand speech and noise. And as you know, this is very common among people who have early dementias and mild cognitive impairments and things along those lines. They will complain that they don't know what somebody just said, or they can't make sense of what's going on around them. So these two things overlap a lot with speech and noise and the inability to understand what people are saying.
That's a big aha moment for me because could be that our patient with hearing loss, it's connected, or hearing loss attributes to dementia from the lack of ability to hear. But also, even if you can hear, it doesn't mean that you can actually interpret that into listening. Is that
Exactly. As a matter of fact, and boy, I'm so glad you mentioned that, because these are numbers that everybody needs to hear. Number one, there's 37 to 38 million people in the USA who would fail a hearing test. That is, they have hearing loss if we were to do an audiogram. Press the button when you hear the beep. That's that very, very simple test. 37 to 38 million Americans will fail that test. But there's another 26 million who have no hearing loss whatsoever. None. They're totally normal thresholds. However, they have supra, S-U-P-R-A, supra threshold listening disorders. And that can be something as common as ADD, attention deficit disorder, attention deficit hyperactivity disorder. It could be mild cognitive impairment, could be traumatic brain injury, could be cochlear synaptopathy, could be auditory processing disorders. There's 26 million people in the USA who will come to see an audiologist or go see a physician because they can't understand what people are saying, and they're going to be told that their hearing is normal. Well, their hearing, their ability to detect sound may be normal. That doesn't mean that their ability to interpret sound is normal. And this is a big, big issue in audiology and otolaryngology. We have to be very, very careful when we tell somebody they passed a hearing screening. Hearing screenings don't really tell you much. And you could pass a hearing screening and have a very significant listening disorder. And it could be in alignment with a mild cognitive impairment or a dementia. And it could also be a speech language problem. And it could also be a million other problems, from Alzheimer's to traumatic brain injury to cochlear synaptopathy to Meniere's disease to a million things. So the fact that you have hearing loss does not protect you from having a cognitive disorder, and vice versa. So these things can coexist in the same person. So when you talk about 37, 38 million people with hearing loss in the USA, it makes sense that they're going to have difficulty understanding speech and noise. But we don't really know that it's 100% auditory, the problem, until we do a cognitive screening and we say, you've done well there, so we're not worried about anything else. It's exclusively an audiology problem. So that's I spend a lot of my time talking to professionals and trying to say, well, why should we do cognitive screenings if the patient has what appears to be a normal hearing loss associated with aging, which is called presbycusis? And the reason is that having presbycusis does not mean you don't also have something else going on. So as doctors, as hearing care professionals, as licensed practitioners, we need to make sure that we do exactly what you learned in medical school. And correct me if I'm wrong, Young, but I'm pretty sure you learned diagnosis first, treatment second. That's how it's got to be for it to all make sense.
Absolutely. So would wearing a hearing aid help to prevent cognitive decline?
Well, there's a lot of literature on this topic. We know that hearing loss tends to exacerbate cognitive decline. That's pretty definitive. There are hundreds of articles on that in the peer-reviewed literature. Now, can hearing aids help to delay or reverse or something like that cognitive decline? Well, the most famous study out there is probably the one from 2015 by Dr. Amiva and her colleagues in Bordeaux, France. And she looked at about 3,500 people, if I recall that right, and three groups. So she had people who said they had no hearing loss, people who said they had hearing loss, and people who said they had hearing loss and wore hearing aids. The people who wore hearing aids were more like the people who had no hearing loss. So with regard to memory. And so what this indicates that, yes, the hearing aids are potentially able to be very, very useful for somebody. And it's not just that study. We have the studies by Anu Sharma and Hannah Glick, which were in Frontiers, and they looked at can we look at patients over time who've been fitted with hearing aids, and will that change the way their brain functions, as far as neuroplasticity? And the answer was yes. They showed anatomic changes and they showed physiologic changes as a result of wearing hearing aids every day for 6 months. And these were premium hearing aids. These are very, very good quality hearing aids that really improved the signal to noise ratio dramatically. And then, there's lots, if you go to the peer-reviewed literature and you put in hearing aids, cognitive decline, you'll see there's a lot of information here, but we don't have conclusive evidence as of 2023. Right now, we're recording this in January. I think there's a John Hopkins study that's going to come out pretty soon, looking at about 900 people over 4 satellite centers, where they're going to look specifically at cognitive decline related to a pivot point, which would be wearing hearing aids or choosing not to wear hearing aids. So they'll look at the long-term degradation and was that the same in both populations, or was it different in those who wore hearing aids? So we're starting. I would say that the indications are that well-fitted hearing aids are always worth trying. Will they slow down or reverse cognitive decline? We don't know. There certainly are some cases where it has happened, and there's some cases where it hasn't happened. So we're early in that process, and a lot of us are looking at that very carefully. So hopefully by the end of 2023, we'll have some very, very significant data out of Johns Hopkins, and we'll also have other studies that are going to break in the peer-reviewed literature, which will lead us to the correct answer. But right now, we have to be very careful because we don't have a succinct and overlaying answer that we can apply to every patient. Every patient is unique. Every situation is different. All hearing aids are different, and so we have to slow that down a little bit and look very, very carefully before we can say conclusively yes or no.
That's really good. Good to know. So I know that most primary care physicians do not do, hearing testing in the office as part of an annual physical. And the question is, should it be done, and how often should it be done?
Yeah, so this is what, for patients who have Medicare, that is the Welcome to Medicare package. Most physicians in internal family practice, GPs, if they're doing the Welcome to Medicare packet, that's part of it. So they're supposed to be doing that. The interesting thing is that when patients self-elect and they tell you, yes, I have hearing loss, or no, I don't, they're wrong a substantial part of the time. And the reason for that is if they can't understand speech and noise, again, that's 26 million who have no hearing loss but can't understand speech and noise, they might say they have hearing loss. And then when we test them, we don't see hearing loss, we see a listening disorder. So how often should you do it? I think whenever you suspect that you're having difficulties understanding speech and noise, or hearing loud enough, that you may actually have hearing loss, I think it's always worth getting a comprehensive examination. I don't mean a screening. Screenings do not tell us enough to tell the patient something brilliant. If we get a screening, they may or may not have other disorders that aren't going to come about as a result of that screening, and vice versa. The answer that I'd like people to understand is that if you suspect you're having difficulty hearing or understanding, you need a comprehensive audiometric evaluation. I would not say get a screening. Screenings are for newborn infant screenings. That's the only time when I recommend them. And it's interesting, most of your audience probably doesn't know, about 99% of all children born in hospitals and birthing centers and things like that across America, about 99% get a hearing screening at birth, because that's very, very important that if we catch hearing loss or deafness in a young child, we need to start working on that within about 3 to 6 months so that their language and their speech doesn't fall behind. And so this is, there's a wealth of information on that, and I'd be happy to discuss it at a different time, but we don't have time to go into that now. But so hearing screenings, I'm not a big fan. I think if you have reason to suspect you have difficulty, you need a comprehensive audiometric evaluation.
Got it. This is screening, I'm thinking, even in the primary care office, we don't necessarily have the device to do the audiometric testing, and that's often
Sure.
the gap is with that. Okay, so what should you do?
Right, and
you do. Go ahead.
Go ahead. I'm sorry.
Yeah.
Well, this is the equipment is not cheap, and it's not readily available in GP offices. I mean, when you think about a medical practice, there's so many things you have to have. And if you're going to have specific tools for vision and hearing and smell and taste and touch, it gets unwieldy very quickly. So I always recommend, you should see a hearing instrument specialist, or you should see an audiologist, and you really want a comprehensive evaluation. And this is not new. The American Speech Language Hearing Association and the American Academy of Audiology and the International Hearing Society all say, in addition to those diagnostic tests, press the button when you hear the beep, the lowest level of screening. In addition to that, you need a communication and listening assessment, and you have to be tested for speech in noise. That's how we quantify how you're doing in noise, and that's how we know how significant a problem that is. If we don't quantify it, if we don't do a speech and noise test, we're guessing.
Absolutely. Here's a question that came in. Where or with who can you get a comprehensive audiometric evaluation? Or what does that step look like to get to that test?
That stuff is about a half hour to 40-minute test. And we can do children, and we can do adults, and we can do senior adults. And it's testing in a soundproof booth, which gives us a lot more information. It's involving everything that most people are familiar with. Press the button when you hear the beeps, and you're in headphones in a booth and all that stuff. But then we're looking much deeper. We're looking at functional assessments. We want to know, how are you doing in real life situations? Because let's be honest, nobody in this world has ever gone out of their house and listened to a bunch of pure tones. It's just not that important. And as far as telling us a functional deficit or a functional ability, what we need to do is we need to replicate the real world. And most audiologists, most hearing aid dispensers can do that in the office. And they can say, this is a normal result. This is how we expect you should be doing in noise. And this is your result. And your result is causing us some concern. So we're going to try perhaps hearing aids or assistive devices or telecoils or pocket talkers or something. And if you fail a cognitive screening, that tells us it might be more than just an auditory problem. It might be that we have some cognitive issues that we want to address. And a cognitive screening is never a diagnostic test. It's a screening, but it gets the patient to Dr. Trin. Because if I'm the audiologist in Long Beach or Seal Beach, California, or Irvine, and I see a patient who has hearing loss that I might expect based on their age and their occupation and their noise exposure, and I want to make sure that once they come to see me, that I do a full diagnostic evaluation. And part of that in audiology is to do best practices, again, communication and listening assessment, speech and noise. If all of that makes good sense, then I would probably go ahead and do a cognitive screening anyway, just to make sure I don't have to deal with that. If the patient does well on a cognitive screening, I don't have a reason to refer them back to Dr. Trin. But if they don't do well on a cognitive screening, I would send Dr. Trin a report of my findings, and I would say, listen, this patient did not do well on this cognitive screening, so I'm going to refer back to you for further evaluation. And at that point, then Dr. Trin would say, well, we can look at this neuropsych, we can look at this through psychiatry, we could look at a speech language pathologist, we could look at whoever else you might want to pull in to get a diagnosis and perhaps treatment.
That's great to know. So most patients come to an audiologist from a primary care physician, I'm assuming, with that referral. With
primary care and otolaryngology, yeah.
I like that. Yeah, I know at RID Medical Group in Irvine, one of the organization I'm with, we would put in a referral depending on their insurance and things of that sort, and go through a network of contracted audiologists to get paid.
And that's such a keen point that you make, because listen, if I'm getting a cognitive evaluation, a cognitive screening in particular, and supposing I'm 70 years old or I'm 80 or I'm 90, generally speaking, with most cognitive evaluations, what happens is I might read a set of questions or statements to a patient. The patient has to then hear and listen to those and then repeat them back. And then I have to write down what I think they said. Well, so now you have 2 points where this can go haywire. It's nice to have a cognitive screener that we can use for people who have hearing loss or hearing impairment or listening disorders that doesn't involve audition. And that's where, we look at things like the Cognitive Thrive, because in that example, we can look at executive function, we can look at memory, we can look at visual spatial, and their hearing loss would not get in the way of giving that test or scoring that test. This is a big issue, and there are some other cognitive screeners that have a hearing impaired version, because it's very important. You can't just presume that a 70-year-old is going to hear and listen because they say they have no hearing loss. The stats in America run like this: 65, when you're age 65 or older, 65-year-olds have about a 1 in 3 chance of having hearing loss on an audiogram. 75-year-old patients have a 2 in 3 chance of having hearing loss on an audiogram. And you know these stats better than I do. When we're talking about mild cognitive impairment, that's about 20 to 22% of people over age 65. And when we talk about Alzheimer's, In the 80 to 85 group, we're talking about 1/3 of Americans. So it's very substantial. And these two groups overlap tremendously between hearing loss, listening disorders, that group, and people who might have dementia or mild cognitive impairment. So it's very important to really do the deep dive diagnostically to find out what are we dealing with, what are the specific problems, and what can we do to help make life a little bit better, to improve the quality of life and the long-term outcomes. Because we know from 2020, the Lancet study by Dr. Gil Livingston and his colleagues, that the 60% of our dementia risk is due to age and DNA, deoxyribonucleic acids, and we can't change either of those two factors. But then 40% are potentially modifiable due to 12 modifiable risk factors. And I know you talk about this all the time, but the number one risk factor, according to Lancet 2020, was hearing loss, and that's 8.2% PAF, which is a population attributable factor. Yeah, so it's pretty substantial.
That's huge. And I don't know that most people realize that that is the number one modifiable risk factor on the Lancet. And that's amazing. And I like the fact that you brought up the CogniView device. And for those who don't know about CogniView, it's cogniview.com. It's a little laptop device that within 5 to 10 minutes will give you an objective assessment of your cognition. And it includes a lot of what you look for in these hearing evaluations that you do.
It really does, because again, going back to where we started, Dr. Michael Bustworth in 1949, when he said cognition, audition, emotions, attention, language, all these things matter, and you can't just take one piece and say, oh, it's hearing loss. Maybe that's true on some people, and that's great if it's that relatively simple, because cognition and other neurologic things are pretty complicated. But if it's simple hearing loss, all of us can help out, and there's a lot of good things we can do, and really change the world. If it's just hearing loss, we can almost always improve the quality of life. But we need to dig deeper to make sure that we know what we're dealing with. When I think about if I go to see, go ahead.
So
I mean, if I go to
with dementia, we normally tell people to seek help early, to do cognitive screening early, to start lifestyle activities early. Is it the same for hearing loss, where the earlier you start to look for this problem, it's better than later?
Absolutely. There's a wonderful study that's very hard to find anymore, but it was done in 1999 by the National Council on Aging. It had about 1,500 people with hearing loss that got hearing aids, and about 1,500 that had hearing loss and chose not to get hearing aids. The people who got hearing aids, National Council of Aging, they had less depression, they had less anxiety, they had less stress, and they had a better quality of life, and they did not undergo social isolation. Because when people have hearing loss that's undiagnosed or that's untreated, they tend to isolate. They tend to not mix with their peers and colleagues and friends and families, because it's very difficult for them to get by. And hearing loss is an invisible disorder. So your friends, families, colleagues, associates, they don't know why you're not participating. They just know that you're not. And so it makes it very difficult. And the earlier that we diagnose and treat hearing loss, the better the results, particularly, of course, in children, right? If we don't diagnose early in children and treat early in children, we can have all sorts of problems, from language to behavioral issues to speech production issues. And we know that children who have hearing loss have significantly less exposure to language. So their brains do not develop exactly the same way as a normal hearing peer might.
Here's a interesting practical question. Should someone go to an audiologist when Costco already have hearing aids that you can just use over the counter? I mean, is there a need to go to an audiologist?
Yeah, great question. And this comes up a lot now in 2023. The answer is yes. None of us will say don't buy an over-the-counter product. That's fantastic. If you can buy a good product over the counter and eliminate unnecessary fees, that's great. But the problem is that you can't tell if you have hearing loss or not. And so a diagnosis before you get treatment is a very good idea. It's the same thing whether we're talking about cancer or heart disease or diabetes, or once you have a diagnosis, then you can manage it. But if you just presume that you have hearing loss and you're just going to go buy an over-the-counter hearing aid, you may be okay. It may be fine. But you know what? It also may be a disaster because you might have something going on that one of us who is licensed in this area would recognize and refer, or recognize and treat. And it does become very serious, because one of the things when we were working with the FDA and the FTC to address these issues of over-the-counter hearing aids was the fact that some hearing loss, some tinnitus, ringing in the ear, can be a sign of very dangerous things like brain tumors, in particular something called an acoustic neuroma. Sometimes people will have tinnitus or hearing loss in just one ear, and that's almost always a sign that needs attention. And patients who are shopping for OTC devices don't know all the red flags, but there are quite a few of them. There's at least a dozen, and they need to be attended to. And it's in the patient's best interest. None of us who are licensed hearing healthcare practitioners would say just go treat that yourself. Just go get 2 Tylenol or 2 Advil. Diagnosis first, treatment second. If the diagnosis is that all you have wrong is that you have a little bit of hearing loss, well, then you should elect to do whatever the most appropriate thing is for you, whether that's OTC or prescription hearing aid. Great. But get a diagnosis first. It's the same with your eyes. No, I don't know any optometrist who says, "Oh, don't use cheaters. Don't use the Walgreens or the Walmart, $12 glasses." That's fine. But before you do that, go see an optometrist. Make sure that you're safe doing that. If you're safe doing that, then great, go ahead and do it. But diagnosis first, treatment second. That's what we've been teaching in medical schools for over 100 years. And the reason that stood the test of time is it's a very, very important step in rehabilitation.
Absolutely, and I appreciate that. Last question. If there was one thing people should remember about hearing loss and the brain, what should that be?
So in 2011, I wrote an article with Dr. Carol Flexer, and that article was called "Listening is Where Hearing Meets Brain." And that's the one thing to remember, that to listen well, to decode sound, to comprehend sound, to make sense out of sound, it takes good hearing and it takes a good brain. So if you just Google "Listening is Where Hearing Meets Brain," you'll get a copy of that article. It's free. And I think that's the one thing to remember. It's not all about loudness. There's a lot that goes into your brain's ability to make sense out of the world.
I love that. It's not all about loudness.
Right.
Excellent. Thank you so much. Very valuable. I've learned a lot myself, and I hope our audience as well, on the importance of hearing versus listening versus hearing loss, and the link to Alzheimer's and dementia. Thank you so much. I appreciate it, and continue to hear more from you, Dr. Beck.
I'm delighted to be here. I'm sorry, we apparently have a 2 or 3 second delay, and I talked over you and vice versa, but I think we got the message out, and I'm so delighted to be here. Thank you.
Thank you so much. All right, take care now. Okay, guys, let's do a quick poll to see what you guys actually learned about that. Let me pull up a poll here for you guys. And here's the question, and you can just type in your answers there under the poll section. Which of the following facts about hearing loss is false? A, hearing aids can only be prescribed by a doctor. B, you can modify your risk for dementia by taking care of your hearing. C, hearing loss can contribute to social isolation. And D, hearing loss comes in middle age, 45 to 65. Which of those is false, guys? Is it A, B, C, or D? A is hearing loss can only be prescribed by a doctor. B is you can modify your risk for dementia by taking care of your hearing. C, hearing loss can contribute to social isolation. Or D, hearing loss comes in middle age. Ooh, that's me. Age 45 to 65. Which of that is false, guys? What do you guys think? A, B, C, or D? What is false? All right. Okay. You guys are smart. 100% chose 100% of you guys chose A, and that is false. Hearing aids can be picked up at Costco, right? Or at Walmart. It doesn't necessarily have to be prescribed by a doctor. So great. You guys are super smart. And I hope you heard me with that. I want to give you guys some resources now, both national and local resources. We'll share some slides here with you guys. These resources, along with others, will be emailed to everyone who signed up for today's program. If you haven't signed up yet to receive our Brain Info Live emails, you can do so by going to this website here to get on our mailing list. It's bit.ly/BIL sign up. And that's how you get on our mailing list, guys. https://bit.ly/BIL sign up. And I want to thank you, everyone. Thank you, Dr. Beck. Great having you here. Thank you, John Lewis, for the incredible exercises. And thank you to all of us, all of you guys, the viewers. Until next time, take care. Bye-bye.